Assalamu alaikum, everyone. It is my great pleasure to introduce the distinguished chair and co-chair for today's. Our chair is Dr. Sheba. Dr. Sheba is an associate professor of histopathology at Al Alim Medical College and consultant histopathology at Gulab Devi General Hospital. She is a distinguished pathologist, and her key achievement is the productive and long-standing research partnership with the University of Virgin Norway. Through this collaboration, she has played an integral role in research and development of an antibody of MPT64 antigen, a critical biomarker for Mycobacterium tuberculosis. And the most importantly, Dr. Sheba is a trainee from Shaukat Khanum Hospital and now serving General Hospital Gulab Devi. So we welcome Dr. Sheba as our chair of the session. Today we are very proud to announce that the co-chair of our session is also an alumni and the trainee of the Shaukat Khanum Hospital, and now a prestigious head of department of Shaukat Khanum as well as a renal pathologist in the region, and he is serving quite a lot of renal centers in Lahore, especially doing MDTs online for them, and as well as the head of departmentship of the Shaukat Khanum Hospital, Lahore. We invite Dr. Mudassir Hussain. Over to you, sir.
Assalamu alaikum, everyone. I'm Dr. Sheba Ishtiyaq. So to start this exciting session of the art and science of surgical pathology, I would like to first give a brief introduction of Dr. Mohammad Suhail, who is our first speaker. He is associate professor in histopathology at University of Bristol and also a consultant histopathologist at University Hospital Bristol. He is also a training program director of Severn Deanery, UK. His research work includes molecular markers in breast and urology cancers. Today, Dr. Suhail will draw our attention to his deep expertise to guide us through his talk titled Update of European Guidelines for Management of B3 Breast Lesions. So please join me in inviting Dr. Suhail on stage, please.
Thank you, Sheba. Thank you, Mudassir, and welcome all the participants. And Assalamu alaikum. So today we'll be discussing and looking at this European guidelines for the diagnosis, treatment, and follow-up of breast lesions of uncertain malignant potential, which we call B3 lesions. I hope you are able to hear me. Are you okay? So these guidelines were published last year in European Journal of Surgical Pathology and developed jointly by EUSOMA, EUSOB, ESP, and ESSO. Before we go into the B3 lesion, I just wanted to remind some of you might not be from histopathology that what are these B lesions or B3 lesions, or how do we categorize these B lesions? As you know, that communication is very important in management of cancer patients or cancer-related patients. So therefore, across most disciplines, I think nowadays these lesions are grouped into 1 to 5. And when we say 2, it means that it's benign, and when we say 5, it's malignant. But life is, as you know, is not always black and white. There are some gray shades there as well. So if we think this is benign, but not 100% sure, we classify them into atypical or B2 or B3. And if we think it's most likely malignant, but it's not enough, and we are reluctant for surgeons to do operation on those cases, so we call them B4. And if it is something inadequate, we call it B1. Now, if you can see over here in B3 lesions, there are wide variety of cases, including AIDP, FEA, atypical lobular hyperplasia, LCIS, radial scar, complex sclerosing lesion, papillary lesions with or without atypia, fibroepithelial lesion, mucocele-like lesion, and most spindle cell lesion, as well as apocrine adenosis. So there are wide different subtypes included into the B3 category, and these are of variable significance. And these lesions can occur with or without atypical ductal epithelial proliferation. If you look at in the research publications that these lesions, B3 category, amounts to about 9% within all the core biopsies. And these are very challenging, not because these are very difficult, some of these do, but mostly challenges because of the limited amount of material we have on the biopsy. So sometimes there can be a sampling error too. So for this reason, these lesions need further sampling either in the form of surgical excision or vacuum excision biopsy. Now, until recently, when I say recently, I'm talking about 2019, 2020, most of these lesions were excised surgically. But if you look at it, the outcome of those excision, these about 74 to 80% of these lesions were benign. And if in the previous NHS BSP guidelines, they compiled this data from various studies up to 2019. And as you can see over here, that the positive predictive value of the overall B3 lesion, not individual, overall these B3 lesion was somewhere between 20 to 25%. And in the current guidelines, European guidelines, they look at it individually, individual types. And obviously, as you expected, that these different lesions have different positive predictive value. For example, AIDEP has the highest positive predictive value, means that they mostly come out, not mostly, but significant number, highest number upgrade occurs in if there is an atypia, which is about 20%. In contrast to flat epithelial atypia and radial scar, this is about 1 to 5%. So the question arises that since there are about at least 75% of the cases they are benign, do they need to go under anesthesia and open surgery? And for this reason, there are various guidelines set up in the previous years, including the NHS BSP, AGO guidelines by German and International Consensus Conference. But then they were from individual countries. So these experts from the Europe, from radiology, pathology, and surgical department, they sat together and did the systematic review of the literature. And they looked at all the data until June 2022, and they critically analyzed these papers. And after critically analyzing these papers, they categorized these into 5 different levels. So if the data or the study was large, randomized, controlled, with low potential for bias, or if it was a meta-analysis with randomized within the randomized trial and without heterogeneity, then they grouped this as to very strongest evidence of level 1. But if these trials were small and there was suspicion of some bias, or if they were meta-analysis with some heterogeneity, so they grade it as a slightly lower level to level 2. And if these were prospective studies, then they were classified into 3. And if they were retrospective studies with case control studies, then they classified into 4. But those which were not any control group, or they were expert opinion or case reports, they were classified as very low level of evidence as level 5. So these pathologists, radiologists, and breast surgeons sat together in Florence in December 2022, and they looked at all this data and analyzed this and the grade and put these different gradings of recommendation. If they thought that there is a strong evidence for efficacy with substantial clinical benefit, they gave it a strong recommendation and grouped as this recommendation A. But if there was a strong to moderate efficacy but with limited clinical benefit, they generally recommended it. But if they thought that it is more or less equal, then it was optional. And if they thought there is a moderate evidence against efficacy, they generally not recommended. And if there was some strong evidence against it, then they say it should not be recommended or never recommended, and group them into group E. So as I mentioned to you and showed you that these are the B3 lesions which are of wide variety. And we look at it, what these are, and what are the recommendations in other guidelines and what European guidelines suggest. So first of all, atypical interductal epithelial proliferation. In this, as the name itself indicates, that there is a proliferation of ductal epithelial cells. And how to diagnose those? These lie somewhere between UDH and DCIS. When we say usual type ductal epithelial hyperplasia, which is completely benign condition, and we call this B2, these patients don't need any further sampling. Whereas if we say DCIS, then they go for excision and classified as B5A. But ADH is not that the quality-wise difference from the DCIS is basically quantity-wise. Means that if the lesion is less than 2 millimeter or involving less than 2 ducts, then we call them AIDEP. So why this new terms contrast to ADH? This new term is because ADH is given terminology is for excision specimen. But if it is in biopsy, you don't know this is the only one duct which you have, which patient has. Yeah, so that's why it needs to be, because if you take more sampling, you may find 3-4 more ducts, and often happens in about at least 25% of the cases. So then surgeon may come back or patient may come back and says, last time you called it ADH and today you are calling DCIS. So we should not be using that terminology. Although this particular guidelines, they have used instead of AIDP, ADH. So I kept those terminologies in my presentation today, but that should be called AIDEP basically. So if the lesion has got even one duct and it's high grade on core biopsy, we go for DCIS. So before we making a diagnosis of AIDEP, it's very important that we should be clear in our criteria. If we see that there is a bulbous end on the micropapillary structure. I mean, as you know that there are different types of DCIS. So particularly in micropapillary DCIS, there should be a thin base and bulbous apex on that. In contrast to another condition which is usual type hyperplasia, which we call gynecomastoid hyperplasia, which commonly we see in gynecomastia. And the difference between the two is that their base is wide and apex is pointed. It's like a pyramid. So if you take this into consideration, don't call these things as a B3 lesion, because then patient will have unnecessary further sampling. So to make sure that you are calling it AIDP, which is truly atypical. And if you have any doubts, obviously nowadays CK56 and ER immunostaining helps. And in neoplastic proliferation, in contrast to UDH, whether this is AIDEP or DCIS, there is uniform strong positivity for estrogen receptor and uniform negativity for CK56. Here you can see there's a mosaic pattern, and this is what you see in usual type ductal epithelial hyperplasia. So the range, so the frequency of upgrade to the DCIS or invasive carcinoma varies depending upon in this usually higher than compared to other types of lesion. So it is in the literature, depending upon how strict the pathologist is, then this varies from 5 to 50%, but average is about 22%. And pool value is after VAB is about 79%. So when they reviewed the literature, they did not find any single factor or combination factor which they can say within the AIDP. If you see this, like for example, age of the patient or family history or something, that these are the factors of individual factor predict more or less in the upgrade rate. Yeah? And also they found that in the literature that there is a lot of controversy about whether further sampling should be done by either VAE or the surgery. But I generally tell you that in UK, the incline is more towards the vacuum-assisted excision, non-operative procedure, whereas in America and also in Europe, they are more relaxed and more favor or tilted towards what you call it for excision. For example, over here, if you look at it, this German guidelines by AGO, that and also by the Second International Consensus Conference, that they said that surgical excision is the first option to pursue after needle biopsies when there is AIDP on the core biopsy. Whereas, as I said, that in UK since 2019, we are following that if there is, whether on the VAB or on the core needle biopsy, there is atypical interductal epithelial proliferation, VAE is the method of choice. Now, there is also some controversy or differences in the opinion about what is the size of the lesion. If the size of the lesion is 15 millimeter, it's easy to excise completely by VAE. And if you have completely excised it by VAE and is confirmed by radiology, then only 5 years follow-up is required as per NHS guidelines. But if the lesion is larger, then there is in different guidelines, there is a different opinion that if it is more than 15 millimeter, then you cannot completely excise it, so go for surgical excision. And as I said, in NHS guideline, we say you still do VAE, but taking the two different areas apart from each other to make sure that there is no DCIS or invasive malignancy. So what did this European guidelines recommended? They said whether you find this AIDP either by core needle biopsy or VAB, surgical opinion is the preferred opinion, because evidence they say is quite strong, because there are large randomized trials showing that there is a high risk of breast cancer in this patient, so they have given the highest recommendation. But obviously when multiple people sit together from different countries and there are certain strong opinion over there, so they came up with some alternate possibilities too. And what they say is that if if the lesion is less than 15 millimeter, you can do VAE, but the evidence and grade of recommendation is 3B over here. Means that there are prospective trial showing that there is efficacy over there, and they have generally recommended this. And if they says if it is more than 15 millimeter, then yes, their strong recommendation is for surgical excision, but you can consider as a second grade recommendation that VAE, like we do in NHS. The second category, I just wanted to make sure how much time do I have? 26 minutes, yeah? Yeah, okay, good. So second category is flat epithelial atypia. And now this belongs to columnar cell change. So initially you see which is completely benign, which is columnar cell change. As you can see over here, I just taken the edge of it, where you can see elongated nuclei, apical snout. So this is a simple columnar cell change. But sometimes there can be atypia too. And this atypia, when they become atypical, the nuclei become rounded, the chromatin is dispersed, and there is some condensation on the nuclear membrane. And as you can see, the difference between the two quite clearly over here. And then you can call it flat epithelial atypia. But the nuclei, when they become high grade, then it becomes flat DCIS. So I think there's a continuum over here, and we have to be absolutely clear when we are calling it columnar cell change, flat epithelial atypia, and DCIS. And there is a significant variation, and you need to have within the department a consensus finding where to go on this lesion. Otherwise, if person is individually reporting, quite often one day quite stressed, they might say, okay, let it call it flat DCIS probably, or today call it FEA. And we in our department, we regularly, day before the MDT, we have a multi-header meeting where we bring all those cases and discuss with and come to a consensus opinion over there. As you know, histopathology is nothing but an opinion. So you have to make a consensus opinion, then there is a most likely that you will be correct. Now, while you're making it, I'm just highlighting some pitfalls over there as well. This one we yesterday looked at it. There is a pregnancy-like change. Again, you can see knob hobnailing over there. There can be some rounded nuclei. There can be prominent nuclei. But important thing is that there is a cytoplasmic and intraluminal secretions there. To have a pregnancy-like change, patient don't need to be pregnant or lactational. These can occur even elderly people, postmenopausal people. You can see these sort of changes too, but obviously focally. Now, sometimes people think that, oh, CK56 and ER is very helpful to identify neoplastic. But in this scenario, flat epithelial atypia is not going to help you, because the differential diagnosis over here is columnar cell change versus flat epithelial atypia, and both are positive for ER and both are negative for CK56. So this is a subjective diagnosis completely on your opinion. So you have to be very clear. Yeah? And risk of upgrade is 5% if there is only pure form. But if there is an AIDP, obviously the risk is quite high, it goes in 20s. So what are the different guidelines? As I mentioned again, currently, there is AGO guidelines over here, which says that that if FEA is found at core needle biopsy or VAB, surgery can be avoided in the following situation only if the lesion is small and is near complete excision. Again, they are saying VAB, where it should be VAE, because when you are talking about excision, it should be vacuum-assisted excision. But if they say that there's a larger area of calcification, then surgical intervention is for them is mandatory. In contrast to this NHS guidelines, as I mentioned, that if you see VAE, then whether it's on corneal biopsy or diagnostic biopsy, you do the VAE. If the lesion is larger, then you sample more than one area. And if you have done VAE, and on the VAE, if you find that there is further this flat epithelial atypia with or without AIDP, and you think there's more calcification there, and there is some mass lesion as well, and there's a discordance between the pathology and the radiology, then in that case, you can do the surgery. So surgery is done in a very small number of cases nowadays in UK. So mostly we manage these lesions with VAE until unless there's bigger or sinister lesion comes up on vacuum-assisted excision. So what are the European now guidelines? European guidelines says that FEA diagnose in the pure form, whether on the core biopsy or VAB without any AIDP or atypia, then they say surveillance is recommended. They don't want even any further sampling, and evidence they say is 2B, means that there are smaller trials available and they are generally recommending. But if there is associated ADH and diagnosis by core-needle biopsy, then the chances of upgrading to breast cancer is very high. So they recommend that there should be surgical excision or VAE, and the recommendation is 2B. But if it is diagnosed by VAB, and if not all calcification is excised, and there is discordance between the radiology and histology, then in that case, they say that you should do surgical excision or VAE, and the grade is 3B, which is the lower. Basically, what they are talking about is that they should be excised much more strongly. So as I said, in their guidelines, most of these guidelines more inclined towards excision, although they are less. Obviously, they are gradually accepting that more and more people or more and more women should be treated with VAE. Now, in situ lobular neoplasia, which encompasses the two histological diagnoses, atypical lobular hyperplasia and LCIS. As I mentioned yesterday, that to make a diagnosis of LCIS, you need to have, if there is only one lobule, if there are more than one lobule, that's fine. But if there's only one lobule, then 50% of the acini of that lobule should be involved by lobular epithelial proliferation. And of that, those acini, not only these lobular epithelial cells filling the entire lumen, not leaving any space behind, but also causing distension. So if this criteria is not met, although this lobular epithelial proliferation is there, they are filling the lumen, they are causing the distension, but you are not sure on the core biopsy is involving 50% of the lobule or not, then in that case, there is a covering terminology is called in situ lobular neoplasia. Again, like AIDEP, you cannot use in situ lobular neoplasia terminology on excision. This is only for the core biopsy itself. Usually, quite often, you see in situ lobular neoplasia with some other lesions like radial scar or FEA, and this sometimes, quite often, not sometimes, quite often, I see associated with calcification. In the past, they thought these are just incidental finding, but nowadays they are associated with calcification and sometimes even mass lesion. Now, in some cases, obviously, when you do reporting, you find that when these are lobules or acini are distended so big, they look like duct. And then it becomes difficult to differentiate from low-grade DCIS. And we commonly do in those cases E-cadherin. And now yesterday I mentioned to you one case in which that if you do E-cadherin and it comes out positive, and you know the majority people thought this may be a lobular cancerization of a lobule, but actually if you look at it, morphology precedence or prevail on everything else. Immunohistochemistry is secondary. You have to think about all the pitfalls in those scenarios. So morphologically itself looks like LCIS, but E-cadherin is positive. Cells are round, regular, monotonous. There may be some lack of cohesion. On H&E, I mean, in most cases, you might not do E-cadherin, but if you have done E-cadherin for some other reason, then you will find, you start scratching your head that you were wrong on H&E. No. What you can do is that do beta-catenin or delta catenin if beta catenin is also positive. And you will find, for example, in this case, that these are negative. So there may be defect either in E catenin molecule itself or intracytoplasmic beta catenin or delta catenin molecule. So they may be lacking or may be dispersed in other places like in delta catenin. Another example, as we discussed yesterday, that these are three subtypes, LCIS, classical, florid, and pleomorphic. Classical, as I showed you previous slide, florid when it looks like a DCIS, where there are larger ductal structure, where the cells are about 40 to 50 across the diameter, and they are closely packed together with very minimal stroma there. And these are, in the Royal College guidelines, are classified as B4. And if they have pleomorphism, variability in size and shape of nuclei, not great, but usually you see prominent nucleoli, then you start thinking about pleomorphic LCIS. Now, seeing a central comedonecrosis, quite often people say this is high-grade DCIS period and they don't do it. But in those cases, when you see it, always look for background. And if you see any LCIS, always do E catenin, and you find that quite often, even myself, I looked at it a few times and I said, can I make it a diagnosis of pleomorphic LCIS? If there was no background classic LCIS, I thought I might have missed it. So it's quite important, be vigilant, look at the slide. If the cells looks like neuroendocrine type, there's a lack of cohesion, then always do, even if it is no classical LCIS in the background, always do E catenin over there, because natural history is slightly different. I don't have much time to go into the natural history, but I'm sure you know that lobular carcinomas are slightly different in behavior compared to ductal carcinomas. So if this is a pleomorphic, then you call it B5A, and they are treated like DCIS. One other thing which I mentioned yesterday, that presence of necrosis does not make it pleomorphic. You can see central necrosis in both florid and pleomorphic LCIS. Now, this risk is wide range in the literature. This is about 27% when you see the in situ lobular neoplasia on the core biopsy. And they looked at it in the SEER population-based study in America. They looked at it and said that what are the method, particularly they looked at age, sex, and date of diagnosis and all that. That's what the SEER data is. And they found that over the years, people are moving away from the surgery. If you remember in 80s, perhaps most of these cases having a bilateral mastectomy. Now, obviously, over the period of time, they have done the limited surgery. But again, this study is from 2017, in which they says 21.4% of these cases still had mastectomy compared to the lumpectomy specimen. But I'm sure over the years, in last 5-6 years, the rate of surgery must have gone down. And in UK, as I mentioned, the guidelines are that we should go for VAE. And there's a slight difference in between procedure as well. It's not just what is the purpose, but the method is slightly different. In VAE, there should be 12 cores, and they have measured it. So these wide bore 7-gauge cores, if they take 12 cores, it comes to about 4 grams of tissue. So you have to make that you have excised the 4 gram of tissue. And if you find only in situ lobular neoplasia or LCIS on the VAE, then you don't need any more surgery, and they go for 5 years follow-up. So in UK, any lesion which has got atypia, whether this is in the form of ductal or lobular, they do have 5 years follow-up after the VAE. Now, this recommendation from the European guidelines is that if you find this on the core biopsy, classical LCIS, and lesion is visible on the imaging, then you can perform VAB or VAE. And if the lesion remains, some lesion remains after the excision by VAB or VAE, then you can do the surveillance, which is justified. And evidence is again quite reasonable, and recommendation is general. But if there is a radiological and pathological discordance, means that there is a mass lesion over there and we're just saying the LCIS, then they say that further surgical excision or VAE is recommended, but the level of evidence is slightly lower. And one thing important, just want to highlight that compared to this study versus international consensus on B3 lesion, they were just voting it. Here, what they are recommending it on the basis of published data, what the evidence is, and on that basis they are doing the recommendation. They also said that you should not be doing bilateral mastectomy or unilateral mastectomy until and unless the patient has got some other risk factors. Like, for example, if there is a family history of BRCA gene, if you are making a decision on that basis, different, but not on the basis of LCIS. And all the cases, you have to obviously consult the patient and they should agree upon the further management. The fourth lesion is radial scar or complex sclerosing lesion. Now, if it is less than 10 millimeter, I'm sure you know that is called radial scar. And if it is more than 10 millimeter, you call it complex sclerosing lesion. And radiologically, why we are saying a scar is not a scar tissue, it's a sclerosing lesion, basically often associated with sclerosing adenosis. In this, you see central area of fibrosis or fibroblastosis containing small tubular structures lined by two cell layer. And experienced pathologists don't need smooth muscle actin or myoepithelial marker for that, and they can easily make that diagnosis. And if you do immunostaining, you'll find that myoepithelial layer is intact. But sometimes there is associated, you have to be very careful that sometimes there is associated invasive tubular carcinoma. And low magnification, experienced pathologists will pick it up quite easily. And obviously in those cases, you will certainly do immunostaining to prove that there is no myoepithelial layer, and then you can say that, so it is important not to miss it. I remember that in 1995, when the paper come out from the Royal Barts regarding the association of tubular carcinoma and the radial scar, and it was about, I think, 10% or something. But that was on the core needle biopsy. And since then, historically, we are going on always on excision side on this. But later on, when VAB came into practice, then the incidence has gone less than 1% now. So again, there is a dispute or disagreement regarding the management in different countries. For example, in Germany, they say if the lesion is 5 millimeter and it is completely excised by VAB, then there is no further treatment required. Whereas, as I mentioned, in NHS breast screening program, we recommend that it should be VAE. And if there is no atypia, either on the core biopsy or VAB or VAE, then there is no surveillance required. They go back into the normal 3 yearly cycle of screening. But if there is any atypia in any of the steps, then they will have a 5 years follow-up. Only atypia, I'm talking about AIDP, but obviously if it is a DCIS, then they will go for surgery. Now their recommendation, European recommendation is that if it is without atypia diagnosed by CNB, core needle biopsy, then should be managed by VAE, although there is not much strong evidence about it, but they are generally recommending it. But if this is a atypia, then as I said, generally whenever the atypia occurs, they are usually favoring that surgical excision, which is their recommended method. But because there are many countries and many pathologists or clinicians, they are still not convinced that they needed it, so they still kept a door open for VAE over here, and they says you can consider vacuum-assisted excision in these cases. Now coming to papillary lesion. As you know that papillary lesion are quite a few different subtypes. Some are basically, when we see papillary apocrine metaplasia, which is completely a benign lesion, and we call it B2. But when we see intraductal papilloma, and if this intraductal papilloma is entirely within a core, which is a small one within the width of the core, then you can safely call it B2 if there is no atypia there. Yeah? But if it is a larger lesion, and only part of the papilloma you are seeing within the core, even with or without atypia, you call it B3. But if there is a DCIS, and I'll come to that in the next slide, when you call this DCIS slightly different criteria, then this will become B5A. And there are obviously in situ and invasive papillary carcinomas too, including papillary DCIS, encysted papillary carcinoma, solid papillary carcinoma, invasive papillary carcinoma. Here you can see this is a cystic lesion with papillary cystic lesion with papillary formation, and these papillae have got very thick cores. And you can see on this even low magnification, they look quite worrying. There's a lot of epithelial proliferation, but if you look at closely, there's a nuclear crowding, overlapping, leftover spaces. All the features are those of usual type hyperplasia. I wouldn't do any immunostaining on these cases. I can see confidently that nothing here to worry. But if you are worried in the initial stages, at the trainee stages, yeah, you should do some immuno, and then you will learn from your own experience. And then you will have more confidence. And you will see that there's a mosaic pattern for both CK56 and ER in those cases. So you don't need to worry about it. You can confidently call it B2. But if you see a larger papillary lesion part of the core, where you can see that there is an interductal papilloma lined by two cell layer, but in some areas you are unable to see the myoepithelial cell layer itself. And the cells are quite florid proliferation over there. And in such cases, usually we do immuno. And immuno, for example, over here, you can see that this portion which I was showing you, that this is a benign interductal papilloma. But in this area, where there is a florid ductal epithelial proliferation, both CK56 and ER, CK56 uniformly negative, and ER is uniformly strongly positive. So these are atypical cells. Yeah? And over here, you can see among these, there are no myoepithelial cells at all. So it's uniform population of luminal cells itself. And here, within the papilloma, you will see intact myoepithelial cell layer. So if then next step is to measure this, measure the extent of this atypical ductal epithelial proliferation. And if it is more than 3 millimeter, yeah, then it becomes the DCIS. You know, the normal criteria elsewhere outside the papillary lesion is 2 millimeter. But within the papillary region, to call it something DCIS, it should be 3 millimeter or more. So if this is 3 millimeter more, then this is called it DCIS originating in interductal papilloma. But also you have to be careful, that those lesions which are entirely made up of these papillary structures lined by two cell layer. So they are intracystic papillary carcinoma de novo. How to differentiate from papillary DCIS is the simple size. I know in WHO book, some people go into that, they say, oh, myoepithelial layer is present usually on, I think in about 80% of the cases of papillary DCIS and 60% of the cases of encysted papillary carcinoma. So what about remaining 20 to 40% of the cases? They can be negative, isn't it? So not on the basis of myoepithelial marker, I differentiate the two. I differentiate on the basis of the size. If this is a larger cystic area, simply is encysted papillary carcinoma. And does it matter? No, because the management is the same anyway. It is the terminology. And often at the periphery of the encysted papillary carcinoma, you see papillary DCIS. It's basically continuation of the process. If papillary DCIS expands, become big and bigger, wider, then myoepithelial layer is stretched and you won't be able to see it. And that's possibly the reason for not having myoepithelial layer in encysted papillary carcinoma in majority of cases. But the disease is for me, is the same. So what is the recommendation? It is the same, luckily, in this time with the NHS BSP guidelines, that if it is without ADH, then you do VAB. We do it VAE, we call it VAE because there are certain specific criteria. Yeah? And level of evidence is 2, and recommendation is generally recommended. But if it is with atypia, like AIDEP, then surgical, or even with DCIS, surgical excision is recommended, and there is a strong evidence over there. Now coming to fibroepithelial lesion, as you know that these mixed tumors, fibroadenomas and phylloides tumor, together are called fibroepithelial lesion, and similar to AIDP and in situ lobular neoplasia, on core biopsy, it may be difficult to differentiate between fibroadenoma and phylloides tumor, because the difference between is, number one, is that leaf-like growth pattern. If you see a lot of cellularity, it can occur in giant fibroadenomas too, or younger patient, but leaf-like growth pattern is one which is very important, or periglandular accentuation, or underneath the epithelium, atypical cells over there. As you can see over here, this biopsy is fragmented. Yeah? So if you see fragmentation, that should be first clue towards it, could this be phylloides? Because of the leaf-like growth pattern, it cuts through and fragment out. Yeah? If you look at it more over here, that these are more fragmentation, and then you see subepithelial accentuation with atypia, moderate cellularity. If you see stromal overgrowth in even core biopsy, that when we say stromal growth, it means that within one low power field, you are not seeing any epithelium, or under two high power field, you are not seeing epithelium. So if you see atypia, significant cellularity, atypia, or stromal overgrowth, then you start thinking about already phylloides tumor over there, even if you are not seeing the leaf-like growth pattern there. If there is a heterologous differentiation as well, which we don't see that commonly, but sometimes do occur very rarely, maybe once in a year. So the risk of upgrade is quite variable in different studies, but its on average is about 37%. But when we are saying 37%, does not mean malignant phylloides. Malignant phylloides are very uncommon. It's less than 2%. So whether you identify this fibroepithelial lesion, whether on core biopsy or VAB, because we cannot differentiate confidently, then excision is appropriate. And that's what their recommendation is. And same we do in NHS BSP program too. Then is a mucocele-like lesion. I mean, mucocele can occur in various organs, and same in the breast, in which you are seeing accumulation of mucin within the stroma. Quite often you see benign ducts at the periphery, which in which there is a mucin there, and you can see the rupture of duct going into the stroma. So this is usually benign. Yeah? But if you don't see any evidence of mucin coming from where, then you don't know whether this is coming from mucinous carcinoma or not. And then you need to worry about. So that's why we call this B3. And within this mucin, usually you don't see epithelial cells. But if you see only occasional, I mean, if you see many groups, then obviously most likely it's mucinous carcinoma. But if you see only one or two groups in the mucin, then it's become atypical. So if it is without atypia, upgrade rate is for 4%. But if it is with atypia, then it's about 21%. So management is basically, if the imaging and pathology is concordant and mucinous carcinoma is excluded, both on, so then you can do open excision or a therapeutic VAE, I should say that. Oh, can be avoided. Sorry. Now, spindle cell lesion, sorry, time is running out. So they have not given any recommendation, but in NHS BSP guidelines, we recommend surgical excisions for these all spindle cell lesions. Now, these guidelines are slightly different from all other guidelines because they have given certain other measures to prevent breast cancer in those cases. They talk about primary prevention, and they say the word chemoprevention should not be used because chemoprevention give you wrong thinking that this may be some systemic chemotherapy over there, whereas here only hormonal treatment is given. There's no specific evidence within the B3 lesion, but the basis is that we give adjuvant treatment in breast cancer patient and seen that there is reduction in second primary in those cases. They have also looked at it that in various trials this primary prevention or hormonal treatment was given, and within those for increases because of various other reasons like family history or BRCA, and within that there were some subgroups in which there were B3 and they found that there was benefit there. And there was also NSAP BP in America, there was a trial, and after that FDA approved this primary prevention there, and later on some people looked at its database and they found that there is a significant risk from 21 to 7.5% in cases with AIDP and LCIS. So this anti-estrogen treatment can help. At the moment, whether it's UK guidelines, UK NICE guideline, ESMO guidelines, they only recommended primary prevention in increased familial risk and not for B3 lesion yet. But these guidelines recommend that they should be offered primary medical prevention, i.e. anti-estrogen treatment. And for premenopausal women, they suggest instead of 20 milligram, new adjuvant treatment, we give 20 milligram of tamoxifen, but they looked at the studies. There are studies saying that lower dose of 5 milligram give more compliance, less side effect, and they can easily, and they are effective too. So premenopausal, because in postmenopausal, there's a risk of endometrial cancer, so you can't give estrogen in postmenopausal. In postmenopausal, you give aromatase inhibitor, but in premenopausal, you can give tamoxifen. As you know, that the lifestyle changes are also important because smoking, obesity, physical activity and alcohol consumption, all these modify the risk. Because if somebody is smoking, there are a lot of data available that increases the risk cancer, obesity because of the increased estrogen production from the fat depot, and lack of physical activity. If you do regular physical activity, it reduces the risk, and alcohol consumption also increases the risk. So what they say is that these people should be consulted and to reduce their or prevent this habit of smoking, alcohol consumption, increase the exercise, and reduce the sedentary lifestyle to remove the obesity. But as I said, there is no direct risk, and it is not possible. And lastly, this is communication is very important, more than in any cancer patient, because there is a lot of uncertainty. And when you are talking to the patient, you need to give the time. You should have a patience with them, and there should be an expertise in communication itself, so convey the risk basically, because otherwise patient might not take the recommendation what you suggest to them. You should give them the time, and also keep in mind the literacy of the patient and their preferences. And you should also provide them some literature and guide them to certain websites. And after that, you should have a follow-up meeting, and you should involve them in the discussion making. And preferably, you ask them to bring a friend or family members so they can help and support them in their difficult times. So thank you very much. Sorry for rush at the last minute.
Okay, thank you very much, Dr. Suhail, for this magnificent and informative lecture. So we must have time for question and answer, but I think it's at the end.
Okay, no problem. Thank you very much. Thanks a lot.
Thank you. So second talk for this session would be harnessing artificial intelligence for precision head and neck cancer analysis. And this will be delivered by Dr. Ali Khanum, who is Dean of School of Clinical Dentistry and Professor of Pathology and Honorary Consultant in Oral and Maxillofacial Pathology. He is involved in research, teaching and diagnostic pathology in oral, maxillofacial and head and neck diseases. He is the founder and lead of Neopath Research Group. His research interests include application of artificial intelligence in pathology. His main clinical research focus is on metastasis and extranodal extension in head and neck cancer, tumor microenvironment, stromal interaction, and epithelial mesenchymal transition in cancer progression. So now it's time for Dr. Ali Khanum.
Thank you very much, and thank you for the invitation to come and share some of the work we've been doing over the last 5-6 years. And we heard about all the subjectivities and difficulties in diagnosis in Dr. Suhail's talk, and that's what prompted me to start looking into AI and its application in head and neck cancer. So I'll just start off with a little bit of a background and tell you a bit about digital pathology and AI, and then give you some examples of how we managed to use it as a prognostic aid. So as you might be aware, digital pathology basically allows us to scan our glass slides, which means we can obtain whole slide images. These are quite large images, and not only are they excellent for teaching, that means that we can actually apply computer vision and image analysis models like anything else. And historically, the problem with pathology has been that it's been analog. So there's been a lot of evidence emerging over the last 10 or so years that AI can help us get better. So as pathologists, we are very good, and we heard about how morphology is the key focus. But perhaps AI can help overcome some of those subjectivities and variations between different pathologists. It's been shown to standardize outputs. It's been shown to maximize or quantify the scores and the outcomes from pathology. And in numerous cancers, it's been shown that once trained by experienced pathologists, AI models can perform to a similar, if not better level. And the other advantage is that none of us can analyze every single cell on the slide. We tend to focus on the area of interest, eyeball it at low power, and then go in and analyze that area. Whereas using AI, we can actually assess every single cell that might be present on the digital slide. So I'll just briefly touch upon some of these terms that might come up in my talk. So classification basically means that we are trying to ask whether there is cancer or no cancer in a slide. In this case, I'm giving an example of a cat. So if the image has a cat or no cat, AI model can tell you whether that's the case. Detection allows simultaneous identification of different types of features. And segmentation means that you can also identify where those features might be present. Okay. Now, pathology images or the digital images are quite different because they are very, very large. So there are no AI models or computers available right now that can take the whole image on its own. So what we tend to do is break it into smaller patches, and then every individual patch is fed into an AI model. Then you get a prediction on each of those patches, and on the other side of the AI model, when the result comes out, we reconstruct it into an image. And this is basically the gist of it. Basically, you are putting in what you think is the output. You want the AI model to decide what is the output. Is it a dog? Is it a cat? In this case, it's a dog. There are different layers in between which work like neural networks of the brain, which are helping a model make that decision. Okay? And it really is up to us in terms of what models or layers or complexities we can introduce in these. And all of us are already using AI in our daily lives, whether you're using Netflix and the recommendations it makes, and Spotify or Uber or Google Maps, etc. So it's not really a surprise that we can apply it to pathology as well, and with some success. Which brings me to head and neck cancer, and we know this is a growing problem. The numbers are continually increasing. The survival and the overall sort of outlook of the disease has not improved for the last 30, 40 years, even though the surgical techniques have improved, oncological techniques have improved. So something needs to change. And here's an example of a T4 squamous cell carcinoma that has come to me in the lab. The biggest challenge is late detection. There are a lot of these cancers are seen or diagnosed at a late stage. We also have a lot of different types of cancers in the head and neck. Okay, the squamous cell carcinoma, of course, is the most common type, but the behavior and prognosis is also quite different, whether you look at oral compared to oropharyngeal and laryngeal. And it's one of those diseases where we do not have any specific therapeutic biomarkers like breast or colorectal or other cancer, where pretty much every patient is being given the same treatment except those that are HPV positive. There are also multiple causative factors, so it can be smoking, smokeless tobacco, alcohol, in some cases genetics as well. So that means the disease itself is very heterogeneous and difficult to treat. So what we need is something that can help us identify these cancers early, or perhaps even before they become cancerous, and something that's a little bit out of the box. And potentially this is where AI comes in. And Hania Mahmood was a clinical fellow in neurosurgery who did a PhD with me. And we started by looking at the evidence and what was out there in head and neck cancer. And this systematic review we did in collaboration with IARC. So head and neck cancers are quite information rich because you've got the pathology images, the radiology images. In a lot of cases there is clinical images as well. And there's no reason we can't apply AI models to get better outcomes, or at least some guidance with regards to how a disease might behave. But what we found as part of these reviews was that although it's an emerging field, there's not a lot of work in the head and neck cancer area. And the work that's out there was not of a very good quality or reliable. So one of the first bits of work that we did was actually in collaboration with the University of Warwick, and colleagues from Shaukat Khanum were also involved, Dr. Sajid sitting here. And what we did was look at developing AI models for automated detection of tumor-infiltrating lymphocytes. So if you look at the top image here, that's the H&E image, and in the bottom image you are seeing the AI model's prediction of where the cancer is, which is red, and the green areas are the tumor-infiltrating lymphocytes. And then we compared these TILs in terms of how they compared for prognostic correlation or survival prediction with other things that we routinely look at, like depth of invasion and grade, pattern of invasion, etc. And it looked like that this automated TIL score was actually a lot more predictive of patient survival over 5 years than any of the things that we routinely use in our pathology practice. And this was done on a cohort of 100 cases from Pakistan. But in a lot of instances, you see different stromal changes in squamous cell carcinoma as well. You tend to see this desmoplasia. And in the cases where you see the desmoplasia, you don't tend to see many TILs, because the stroma tends to stop the TILs from getting into the tumor. So we decided to expand on the work a little bit, and then wanted to look at how the lymphocytes in the stroma might be actually important or not. And this was on a bigger cohort. So we looked at, of course, the cohort from Shaukat Khanum, but also TCGA. and also a predictor, which is a UK trial of oropharyngeal carcinoma. And what we found was, so again, as I mentioned, the pathology images are quite big, so you break them up into smaller patches, and then these go into an AI model, and here's the prediction on a whole slide image level, where red is the tumor, and then we try to localize or identify where those lymphocytes were, or what type of those lymphocytes were. So whether they are inside or close to the tumor, whether they're in the stroma, etc., because we wanted to look at the ones that were relevant and close or in the stroma adjacent to the tumor. And here you can see an example of this stromal lymphocyte score and how predictive it is in terms of patient survival over the next 5 years. And building on that work right now, I've got a PhD student, Jiang, who's looking at this social network of cancer cells in head and neck cancer. We've got a multi-center cohort and thousands of cases, and we were developing this automated pipeline where we don't only identify whether there are lymphocytes present, but we're actually looking at the correlationship of different types of lymphocytes as well, and try to come up with a stratification score in head and neck cancer. So here's an example, whole slide image. You basically just delineate the area of interest on the slide, and here you can see that the models are picking up different types of cells automatically. So the red cells are the tumor cells, blue are the stromal cells, and the green ones are the immune cells. So every single cell is being automatically detected. But then using that, we can actually, on the TCGA, we've analyzed this and the prognostic potential of this. And on 300 patients that we've analyzed so far, it looks like that you can very nicely stratify patients into high risk and low risk categories, which means it can perhaps help us decide whether to treat these diseases more aggressively or not. But not only that, we can identify the different types or exactly where those lymphocytes might be present. So we can draw these little maps between the lymphocytes. So for example, whether they are inside the tumor, whether they are in stroma, or whether they are at the interface of the tumor and stroma. So you can see every single cell can be identified, and then you can build these little networks between them. And that can tell you what type or subpopulation is the most prevalent and might be playing a role in the biology or progression of the disease. And you can see all of these actually give you an indication of most of them, if not all of them, are important or significant. But right now we're working on something that actually covers all three across one score. But one area that I've been really actively involved in is oral epithelial dysplasia, because if we can identify the cancer or the risk of cancer before it develops, that will be a massive help, because a lot of these lesions will have dysplasia before it develops cancer. But as we know right now, they can have different clinical presentations. Not all dysplasias become cancerous as well. Just a rough drawing in terms of how healthy and dysplastic epithelium looks. I don't need to tell this audience, but you can see the abnormal cells and the disorder stratification and the bulbosity of the Redi processes, etc. But a lot of that, or all of that right now, is subjective. And what we tend to do is these three categories of dysplasia: mild, moderate, and severe. So not only are we thinking about all of those features, then we're also thinking about the thickness of the epithelium that might be involved. So it's quite an artificial line to draw in your mind, and then based on that, you're giving a score or a grade, which is meant to guide treatment. So there's no surprise that there is a lack of agreement, and different pathologists grade dysplasia differently. And it's not helped by the fact that the WHO, instead of reducing or consolidating the number of features we meant to look at, has increased the number of dysplastic features from 16 to 28 in the most recent classification. So we feel like that's actually going to make the problem even worse. So what we did was develop this whole pipeline in terms of attacking the dysplasia problem from multiple angles. So first of all, we wanted to see whether all of these features that the WHO prescribes, actually, are they all important or as important as each other? And what we found was that this was a cohort which was looked at independently by 3 pathologists. And these 6 features were the one that kept coming up and was significantly correlated with transformation, so whether a dysplasia became cancerous or recurrence. Now looking at them, they look fairly obvious. Okay, yeah, these should be related, but this work has never been done. So we wanted to start off by doing that to see what features we can use to train our AI models. And then based on that, we thought, okay, can we actually just do something even before we start using AI? So we came up with a 6-point model. So instead of looking at all the 26 dysplasia features, why don't we just look at these 6 and give a point for each of the features that's present? And that performed really well in terms of transformation accuracy of nearly 80% and recurrence of 77%. And the 2-point model, which was the 2 features between those 6 features that had the highest level of agreement between pathologists. And even that did quite well, 77% accuracy. And we published that in Modern Pathology, but we wanted to compare it with WHO and the grading system, and you can see that performed quite poorly with the transformation accuracy of around 60%. So instead, it looks like by looking at a few features, we might actually get better at predicting whether dysplasia will become cancerous or not. Then we also assessed it in an independent external cohort as well. So as you can see that our 6-point model actually improved. It went up to 0.81. 2-point model still performed okay and was better than the WHO and the binary grading system. But again, this validated that actually this is something that potentially can be useful for the pathology community. And since then, we've assessed and compared all the different grading systems for oral dysplasia as well and published in Histopathology, and found that the 6-point model actually seems to work as well, if not better than any of those models, and simplifies the diagnosis. The next thing we did was look at quantifying some of those features that we see in dysplasia. Okay, so we looked at things like nuclear circularity, eccentricity means how central the nucleus is, how much hematoxylin is present in a nucleus, and also the nuclear to cytoplasmic ratio. And using those, we developed these multivariable models. And it looked like that the circularity of the nucleus was significantly correlated with the recurrence of a dysplastic lesion. And similarly, if you look at malignant transformation and the recurrence risk there as well, again, quite a good accuracy of 77%. And if you compare it to WHO, that only showed an accuracy of 69%. So again, these are the features that the WHO actually does prescribe, but we don't tend to quantify them. So by quantifying some of those features, we can actually make our predictions better. Then we decided to look at mitosis, and mitosis counting has been quite prominent feature of breast pathology for a long time, but it hasn't really caught up in head and neck. And what we wanted to do was look at manual counting of mitosis on digital slides, but we also use PHH3, which is the most specific mitosis marker in these dysplasia slides. And what we found was there was a correlation with the total number of mitoses in the lesion and whether it became malignant or not, but also it related well to the grade of the histological grade of the lesion as well. So here you can see that again the accuracy is around 78% in terms of looking at the total number of mitoses and whether a lesion can become cancerous or whether it recurs. Whereas if you compare it to WHO alone, it's significantly inferior. And this was published in Virtue's archive. And then we moved on to more sophisticated methods. So first of all, we started with machine learning. Machine learning is a branch of artificial intelligence. So we use 185 slides of dysplasia with the outcome data, normalized the stains, then told the models where exactly the dysplastic cells or regions were. And then we tried to get a prediction on unseen cases. And as you can see here, this artificial neural network model can identify a dysplastic cell down to a single cell level with an accuracy of 90%. So this was really good. And here's another example. This is non-dysplastic epithelium in the test cohort, just hyperplasia, and you can see the models are correctly identifying it as non-dysplastic, whereas here is more dysplastic-looking epithelium, and the red dots here are all what the model thinks are dysplastic cells, and the greens are non-dysplastic cells. And after that, we moved on to more advanced deep learning AI techniques. And for that, we use some state-of-the-art models. So the transformers are usually quite, these days, very popular, and they are quite sort of advanced AI models. Here is an example of a dysplasia whole slide image. And you can see these deep learning models automatically identifying and segmenting where the dysplasia is in the slide. But not only that, we could also get this sort of hotspot type activity in the sense of which areas or regions were contributing to a model's decision of whether something was dysplastic or not, because we wanted it to be explainable and we wanted to see whether what the model is picking actually makes sense. So when we looked at it closer, all these areas which were lighting up in these predictions by AI models had quite a significant number of these periepithelial lymphocytes. And when we looked at the prognostic potential and the risk, malignancy risk of these lesions, what we found was that the high number of periepithelial lymphocytes was correlated to a high risk of malignant progression, much more so than any of the other features we look at and think about in terms of dysplasia. There was also a significant correlation for nuclear to cytoplasmic ratio. So that means although we look at a lot of epithelial features, we don't tend to usually consider the immune infiltrate in the dysplasia diagnosis, but it looks like it may have a role to play. So then we built on that, and we wanted to also look at whether there's a role for intraepithelial lymphocytes. And again, this is an automated AI pipeline. You can see that the transformer model is being implemented. You can identify where the dysplasia is. And then within the dysplasia region, you can actually take away every single nucleus and do hundreds of different measurements and correlations on that. And then based on that, we could identify or come up with these intraepithelial lymphocyte scores. And what it looked like was that these intraepithelial lymphocyte scores, whether they were across the slide or whether they were in the peak areas, were significantly better predictors of whether a lesion was going to transform and become malignant than WHO grades. If you look at the survival curves here as well, there's a better separation between mild dysplasia, but then moderate and severe dysplasia get all muddled up. And this is the main area of diagnostic problem. Whereas if you look at just intraepithelial lymphocytes, it looks like that you can very easily stratify these lesions into high risk and low risk with regards to their malignant potential. And this is perhaps something that we can start encouraging people to use in their practice, even if it's manual IEL counting. And then all of these models that we've been building all this time, we just thought, okay, now is the time to actually bring all of this together. And again, this was work funded by Cancer Research UK. We worked in collaboration with colleagues in Warwick, and we came up with this automated AI pipeline, which we call ODIN, which is Oral Dysplasia Network. And it does the similar thing. This is a much bigger cohort, 456 cases from 4 different centers. You identify automatically where the dysplasia is, and the accuracy of dysplasia diagnosis is 96%. So we're making sure we're not missing dysplasia. Then after that, we can identify where in dysplasia are the areas which are predicting to that malignant risk potential. And for the malignant risk, we had a transformation accuracy score of 75%. And as part of that, we've also built this demo as well, just to show you how the model works in real life. So here's an example of a whole slide image of a dysplasia. Okay, so you can identify every single cell. So here we are automatically identifying where the epithelium is. So that's all turned green. Then we want to look at individual epithelial cells. So it will pick up every single nucleus within the epithelium. And after that, we wanted to tell us where is the dysplasia in this epithelium, and the red area is automatically identifying where the model thinks dysplasia is present. But we can also look at other cells in the stroma as well, how many lymphocytes or fibroblasts or other cells might be present as well, and do all sorts of analysis on those as well. And this is at quite an advanced stage. Actually, we're going for an MRC grant now to test this on 15 other centers and hopefully take it to clinical application maybe in the next 4 to 5 years. But we're also trying to understand the biology and or nature of what's happening on, because usually in cancer, the higher number of lymphocytes is associated with a better prognosis, but it looks like in dysplasia it's the other way around. So we're trying to see what the phenotype of these lymphocytes might be. So we are doing some multiplex staining on these dysplastic cases to see how these might be different to lymphocytes in cancer. And then what we can do is develop AI models based on these multiplex images and again perhaps feed that into our existing models and make our prediction even better. Now, when we were developing this work, we presented it to quite a few patient groups. So we work very closely with patient charities, head and neck patient charities, and they all quite liked the idea. But the main comment was, someone still has to identify the lesion and send it to a hospital for it to have a biopsy. So can we do something which can actually help doctors and dentists in identifying which lesion might be risky and need to be referred? So what we did was we started looking at clinical images, because they tend to be, at least in the UK, photographs are taken as a standard for white patches. So we started collecting these images of dysplastic and non-dysplastic lesions from UK and colleagues in Brazil. And then we trained AI models to automatically identify whether something was suspicious, i.e. dysplasia, or non-suspicious or benign. And here you can see this white patch is being picked up by the AI model, and the red areas are indicating where the model thinks might be the most suspicious looking areas. And then we built on this work, got some more funding from Cancer Research UK, in which we have developed this automated pipeline in terms of the clinical image going in the model, but not only just identifying whether it's dysplastic, but also trying to now predict the behavior and prognosis of the lesion as well, and whether it's going to become malignant or not. So here's an example of this further work. Again, you can see non-dysplastic is in green, cancer is in red. We've added an extra class, so it's benign or non-dysplastic, dysplastic, and cancer. Okay. And you can see these predictions here of the model identifying or picking where the lesions are and what their likelihood of diagnosis is, which can hopefully one day help clinicians in terms of referring patients or deciding which lesions to biopsy or not. And if you look at the accuracy or the performance of these models, then the best performance model actually has an accuracy of 85%, which is quite good. I mean, it's not 100%, but none of the humans have 100% performance, so it's definitely better than what we have already. And this is on a cohort of 800 to 900 patients overall. Another area I'm quite interested in is larvae gland tumors, and they are quite challenging. We got 38, 39 different types of tumors. They can look very similar. Some of them can look just like breast tumors as well. And you can also get, within the tumor, you can get a lot of heterogeneity. So on small specimens, even detection of whether it's benign or malignant can be challenging. So a PhD student of mine looked at whether you can use computational or AI methods to identify whether something was benign or malignant tumor. So we looked at, sorry, let me go back to the last slide. First looked at whether we could tell whether a lesion was benign or malignant, then whether it was high grade or low grade, and then we also tried to automatically subtype 4 of the most common types of these salivary gland tumors. And this was only recently published in scientific reports, and basically here you can see is a classifier. On the top is a pleomorphic adenoma, I think, and it's automatically being picked up by the model as predominantly green, benign, whereas at the bottom is a malignant tumor being picked up as malignant. When you look at the subtyping again as well, we looked at mucoepidermoid carcinoma, actinic cell carcinoma, adenoid cystic carcinoma, and carcinoma XPA. And again, the specific subtype is highlighted in that color, and you can see it's doing quite well in picking up the subtype of the tumor. But also we could very nicely automatically grade a lesion of whether it was high grade or low grade without any subjectivity. And the accuracy we were getting was close to 95%. And then we built on that work since then. So LifeArc is a rare disease charity in the UK, and we got some money from them. And then we tried to apply more advanced AI techniques to these salivary gland tumors. And what we found was that, again, our models are performing quite well. C-transpath is, again, a transformer-based model, and that can separate benign or malignant tumors even based on small and core biopsies with an accuracy of 88%. Here's an example. You want, these days with AI, you want some explainability as well. So the areas that it's looking at, are they actually relevant areas, and what's actually contributing to the decision? Here is an example of a carcinoma, pleomorphic adenoma. You can see the model is picking up where the tumor is, and the red areas are the ones that are predicting to the model's decision of whether it's malignant or not. And you can see it's all in the relevant or tumor areas, and it's not picking any red or hotspot areas in the non-relevant tissue areas. Now, one thing that's changed a lot over the last 10 years or so is HPV testing, with the sort of increasing number of HPV positive head and neck squamous cell carcinoma, particularly in the West. These patients don't tend to have the usual risk factors or habits, but there are a lot of different subtypes of HPV. So that means, of course, we need to do P16, but P16 is not specific enough on its own. So particularly in the UK, you need to do either in situ hybridization or PCR to confirm that for head and neck cancers. That means there's a delay. That means there's also a cost as well. And also, a lot of the places in the world don't have access to all of those testing facilities. So what we wanted to do was develop an AI model which can try and predict the HPV status without the need of doing the test. So this again was done in collaboration with colleagues in Warwick, and what we did was we looked at the texture features of the nuclei in HPV cancers, the colors, and basically just combined them together. And the model could actually perform or predict HPV presence in a sample with an accuracy of 93%. This again was published in Modern Pathology. Here's a true HPV positive squamous cell carcinoma. And here's the model indicating the likelihood, so the red areas are more likely, and this one is saying that it's more than 95% likely to be HPV positive, which it was. So hopefully something like that can make life a lot easier for people who don't have access to all those tests. And that also means that within 5 to 6 minutes, you can get a result on a cancer which can tell you whether this is a HPV positive cancer or not. So it looks like I'm finishing ahead of time, which is good. So to sum it up, I think there is quite significant potential for these digital methods to alter the way we assess our cases. It can make us better, and it can allow us to provide better outcomes for our patients as well. In terms of the risk prediction and variations between pathologies, we can try and overcome some of those challenges. We can develop early interventions as well, and perhaps we can identify some of these cancers before they even develop. But as you can see, the AI or computational work is very heavily dependent on data. So the quality of the data from multiple centers, but also expertise from different backgrounds, whether it's computer science, pathology, oncology, etc. You need to come together to develop tools that are actually useful for patients. Just wanted to thank everyone who's been involved, and of course the funders who've helped fund some of this work. And thank you to all of you for listening.
Thank you so much, Dr. Ali. It sure was a wonderful presentation, and I'm sure it will turn out our microscopic version of the things that we see into a more broader approach by the AI. So we'll take the questions at the end then. And our third speaker, will he be online? He'll be virtual. So our third speaker is Dr. W.M. Tilkaratne. He's currently the professor of oral pathology and senior consultant attached to the Faculty of Dentistry, University of Malaya. He has held many academic and professional positions, including Professor of Oral Pathology at the Queen Mary, University of London. His main research areas are oral cancer and oral potentially malignant disorders. He has published over 160 papers with an H index of 43, written 2 textbooks, and contributed to more than 30 chapters. He's an editor for the WHO classification as well. So today, Dr. Tilkaratne's presentation delves into one of the most pressing challenges in the field of histopathology, and the topic is histopathological parameters of prognosis in oral squamous cell carcinoma.
Good afternoon, everyone.
Thank you.
First of all, let me thank the organizers for inviting me to speak on this August forum. Let me share my screen. The topic that I'm going to talk to you is the histopathological parameters of prognosis in oral squamous cell carcinoma. Before coming to the topic, let me just show you where I work. Now, most of you may have seen this city, Kuala Lumpur, a vibrant city in Malaysia, fast developing city. And our university is situated in Kuala Lumpur, toward the edge of Kuala Lumpur. So you can see it is a very green university. And it occupies about close to 900 acres, so very big. Look at this. This is the medical and dental faculties of University Malaya. Now these buildings are Faculty of Dentistry, and these buildings on right side are the Faculty of Medicine and the main University Malaya Hospital. University Malaya is one of the main universities in this part of the world. You can see it's ever increasing university ranking. Now we are 58th in the world in QS university ranking. Well, now getting to the subject. What is oral cancer? I don't need to explain what oral cancer is to this audience. But in general terms, any malignancy that occurs in the oral cavity can be called oral cancer. But we all know the oral cancer, when we say oral cancer, it is almost synonymous with oral squamous cell carcinoma. That's because more than 95% of the oral malignancies that we see are squamous cell carcinomas. Of course, we get many different types of salivary gland malignancies and also different types of sarcomas that we see in the rest of the body. Now, these are the usual pictures that we see in this part of the world. They present fairly late, stage 3 and stage 4. Now, with this kind of fungating masses and also with massive regional metastasis. Now, any clinician or pathologist dealing with cancer should know some key facts about the common cancer. Now, we all know the fact that most oral cancers precede some form of oral precancer. Now, we don't use the term oral precancer. Now, we call them as oral potentially malignant disorders, simply because not all oral precancers turn into cancer and various other things, but they all have the potential to become malignant. They have the histopathological and the molecular attributes of becoming a cancer. And also the early diagnosis of these precancers or OPMDs reduces the incidence of cancer. That's very clear, so that should be the target of the clinicians. Some precancers transform into cancer, as I said earlier, not all of them. In fact, a minority of precancers transform into cancer, depending on what particular type of precancer or OPMD we are talking about, because there is a list of OPMDs, but when it comes to our part of the world, oral submucous fibrosis is the commonest OPMD or precancer we see, and then leukoplakia. Early diagnosis, of course, is the key for better prognosis, not only to reduce the incidence. T&M staging is critical in drawing the treatment plan. That is what most clinicians use to draw up the treatment plan. However, a very important and the critical role that can be played by histopathology is not taken 100% correctly in most countries. We know the pathology of a given oral cancer is a predictor of prognosis, various the parameters. And also the pathology of a given cancer should be used to decide or draw up the treatment plan. Of course, the clinicians can use not only the histopathological, and they can use other conventional things, but histopathology should play a major role as well. Now, what about the oral cancer problem in Asia? Yeah, it's a common cancer, very common cancer when it comes to South and Southeast Asia, mostly South Asia. In some countries, even in Pakistan, Sri Lanka, in males, the number one cancer is oral cancer. So that tells us it's a significant health burden to this part of the world. You can see even in this diagram, the Pakistan has so many oral cancers in numbers, second only to India, China, and Bangladesh in Asia. So that tells the clinicians, the pathologists in Pakistan should be aware of oral cancer in very detail, not only clinical, even the pathology. Now, when you look at the cancer burden in Pakistan, so I got this graph from this Muhammad et al. Publication. And you can see in males, oral cancer by far the commonest cancer compared to other cancers. And females, still, it is high up. The third rank cancer, according to some studies, it is second rank cancer, even in females in Pakistan. So that again, I reiterate that because of the commonality of the oral cancer in this part of the world, we should be aware of all aspects of oral cancer. Now, this is the reality in this part of the world, especially. We have, as I alluded to you earlier, the two cancers, pre-cancers commonly, oral submucous fibrosis and leukoplakia. Now, submucous fibrosis, we know all the problems that these patients have. They can't open the mouth, they can't put the tongue out, the oral cavity is cement-like, so very hard oral mucous membrane, and they do become cancer. And leukoplakia, again, the same thing. But what happens is when these patients present at this kind of late stage, the surgeons have to do very radical surgery. Now, you see almost the whole mouth is out here. So this treatment alone will take about 20 hours to microvascular reconstruction, etc. And it is not economically viable to a developing country. So therefore, the aim of oral cancer treatment as a whole should be to diagnose them early, if possible, at the pre-cancer or PMD stage. Now, these are the patients that come to us at very late stage. It's a known fact that, especially in our part of the world, 70% or more of our patients present at stage 3 or stage 4, where surgeons can't do much and the prognosis is not very good at all. Now, what are the prognostic markers that one can use to predict the metastatic potential and the survival, overall survival, recurrent pre-survival, etc.? Well, clinicians like to use clinical parameters more commonly. Of course, they're combined with TNM staging and the size of the tumor, nodal status, etc. So they are very important. Nobody can argue against that. And then histopathological. So we should use histopathological parameters, which are important in prediction of prognosis, to a better effect. According to my understanding, we do not use globally the histopathological parameters to good effect, although they are very significant. Then molecular, as we all know, we are living in developing part of the world. The molecular facilities are not very available in terms of diagnosis and in terms of treatment. Now, the question that we need to ask, are they accurate and helpful in routine clinical practice? Probably for some of the things, definitely the answer is yes. For clinical, clinicians prefer to use them and most commonly practiced. So without any argument, these clinical parameters, combining TNM staging, that is the most commonly used one to predict prognosis. Histopathological, are they accurate and helpful? Yes, they are, but usage is not adequate compared to their significance. I reiterate this, usage is not adequate compared to their significance. So that is the reality. So then what should we do? We should have better methods, better understanding should be transmitted to our clinical colleagues how histopathological parameters can be used to good effect in order to plan their treatment properly. Molecular, as I said earlier, numerous markers have been identified, especially in other cancers to good effect, but the significance of molecular things in oral cancer needs more research and validation. But compared to other cancers, the molecular facilities are used very rarely in oral cancer management. We know there are some things that people use, like EGFR receptor, the antagonist, because EGFR is one of the most mutated genes in oral cancer, so that is being used to some effect in some countries. But now new the molecular or targeted therapy in terms of immunotherapy is coming up, like PD-1 and PD-L1. So those things will come in the future, but the question is whether we can afford to use it in our part of the world. So now we are into the subject proper in my topic. According to my topic, what are the histopathological parameters that can be helpful in predicting prognosis and planning treatment? Well, there are numerous histopathological parameters that researchers have described over the years. We know tumor size. Tumor size, clinicians use the clinical tumor size, and also as pathologists, we measure the histopathological tumor size in order to give them the pathological TNM staging. Depth of invasion, a crucial and the critical thing, I will come to the details in a while. Tumor thickness and depth of invasion, they are slightly different, but more or less same. But depth of invasion is the one that we use more because it is more scientifically viable. And the degree of differentiation, this has been used from 1920s after Broder's classification, as well moderate and poorly differentiated cancers. Pattern of invasion, similar to depth of invasion, another very significant histopathological parameter. Lymphocytic host response. So we know the role played by lymphocytic host response. Now the latest things coming, the prognostic value of tumor infiltrating lymphocytes to the TIL. It has been included in Royal College of Pathologists guidelines as well as a non-core element. And the tumor stroma ratio, again, a recent addition to histopathological parameters. We know the stroma-rich tumors behave poorly compared to stroma, the poor tumors. The tumor body, again, the fairly new concept. The excision margins, the traditionally clinicians are very keen to look at the histopathology report to see whether they are clear of their margins. And the lymphovascular invasion, again, one parameter that can be used to clinically negative necks in order to decide the elective neck dissection. Perineural invasion, bone invasion, another very important histopathological parameter in order to decide whether they are going to sacrifice mandible or maxilla. And the presence of human papillomavirus, if you have facilities, I think that should be conveyed to the clinicians, because we know the human papillomavirus positive oral and oropharyngeal cancers are more chemoradiation sensitive. And of course, now you can see the list of histopathological parameters. I think if one is going to use them as a whole, as in deciding the treatment plan or prognosis, I think we need prognostic models combining the most significant histopathological parameters. Now, what I've said and done, now these are the most important things for clinicians. So that is what they look at, although I said some of the things are very important. They look at the tumor size, the excision margins, lymphovascular invasion, and bone invasion in planning their treatment. Now, how can these histopathological parameters help in the management of oral squamous cell carcinoma? Well, it helps to predict whether there is metastasis or going to be metastasis or not, especially when the neck is clinically negative. It's a very important thing that if the clinician can predict the possibility of occult metastasis in a clinically negative neck in order to plan the treatment. Selecting treatment option, whether you are going for a radical treatment or slightly conservative, or what kind of neck dissection is going to be used, etc. Now, they all can depend to some extent on the histopathological parameters. And of course, the further management, especially for surgery for residual tumor or some other management that adjuvant chemo, radio, etc., can be decided with the histopathological parameters coming from the excision report. And of course, as I alluded to you earlier, prediction of survival can be made to fairly accurate extent by looking at histopathological parameters. Now we look at some of the histopathological parameters in little detail. Depth of invasion and tumor thickness, as I told you earlier, we'll focus more on depth of invasion because that is what we normally use. Now, we need to remember the fact that now the new ADAC classification, depth of invasion has been added in order to decide the T stage of the tumor. So I think that is a good move. So that gives the accurate T staging of a tumor. I'll come to that when we discuss this in a little detail. The depth of invasion, yes, we all know. We don't look at the exophytic component, but we get from the basal membrane to the deepest end of the invasion. So that is the depth of invasion. But tumor thickness is the thickness of the whole tumor from the extreme upper surface to the lowest part. Especially exophytic tumors, there's a drastic difference between the tumor thickness and the depth of invasion. So the depth of invasion is one of the determinants of the latest AJCC edition. So what happens is now earlier the T1 means the tumors which are less than 2 centimeters. Now although it is less than 2 centimeters, the depth of invasion is more than 5 millimeters. Now it is upstage to T2 stage. Likewise, T2 can be upgraded to T3 with the depth of invasion. So very important. I think it is now scientifically and research-wise proven that that is the way to go. And also the depth of invasion is significantly associated with higher the depth of invasion, shorter the overall survival, disease free survival, etc. And this is specific survival, excuse me. And also depth of invasion serves as the predictor of cervical lymph node metastasis. As I said earlier, swell the neck is clinically negative. Now, depending on the DOI, clinicians can decide whether they are going for elective neck dissection or not. So END is of course recommended depending on the risk of occult metastasis. Now to decide the occult metastasis, of course, according to a recent study coming from Cruz et al., the DOI is independent predictor. Remember, it's an independent predictor of occult metastasis. So therefore, we should use that. And DOI is the most significant historical predictor of subclinical cervical node metastasis in early T1, T2, and node SCC with a DOI of more than 5 millimeters, right? That indicates, when DOI is more than 5 millimeters, it's fair to think of elective neck dissection. And the cutoff value of depth of invasion varied with time. Now, if you, with different countries and according to different studies, cutoff values range from 2 millimeters to 10 millimeters. But until recently, it was accepted the fact that DOI of more than 4 millimeters should have been considered as accurate cutoff value for performing elective neck dissection. But now it is more 5 millimeters according to new AJCC. That is the landmark that we use for depth of invasion. In summary, for depth of invasion, DOI is a critical histopathological parameter to predict and plan treatment. While it serves as a valuable predictor of metastasis and aids in treatment decision plan making, further research is necessary, especially from our part of the world, in order to decide the cutoff value, because as I always say in all my lectures, the oral cancer that we see in this part of the world is not the same cancer that we see in the Western world, because our etiopathogenesis is different, our extracellular matrix is different, and therefore the invasive capacity of these the cancers are not the same as the cancers without betel-quid twin. So therefore, that is where we need more research coming from clinical and pathologist collaborations, clinicians and pathologist collaborations, in order to decide the realistic cutoff values in this part of the world for oral cancer, depth of invasion. Pattern of invasion, again, a very important histopathological parameter. Right? There are various the pattern of invasion classifications came in, but we advise you to use the ICCR, that is the Intensive Collaboration for Cancer Reporting. We did a couple of revisions now to ICCR classification. It is free of charge. If you go to ICCR website, you can get the whole database, and please try to record all the data according to the database. Then you have a very good database to analyze your results and to look at various parameters, how they are important and effective, etc. Now, this one classification, you see where you have type 1, the very cohesive islands, and large islands, they both go as cohesive. And then you have type 3, type 4, and type 5 in this worst pattern of invasion. So they are all discohesive. But the worst pattern of invasion in the type 5, there are more individual cells, so tumor buds away from the main tumor by at least 1 millimeter. So they are again discohesive, but in the ICCR, we label them as disperse. In the ICCR classification, therefore, we have three patterns: the cohesive, non-cohesive, and disperse. Now, this is mostly the type 1, 2, and 3. The non-cohesive is type 4, and disperse is type 5. So that is how it goes. So you have here the large islands with pushing border, and here small islands and narrow strands. They are usually less than 15 cells in width. And here the individual cells, they are mostly individual cells. They are 1 millimeter away from the main tumor. So that is dispersed. Now, these things correlate very nicely with the risk of metastasis. So there are a lot of research on pattern of invasion. We started looking at pattern of invasion long years back, about 25 years back. We produced the first paper on pattern of invasion and its significance to metastasis. And now the current evidence suggests that it is an independent predictor of prognosis. We have shown that with our recent research many times that pattern of invasion can be a predictor of prognosis, independent predictor of prognosis, even metastasis, also mostly metastasis. Now, when you have the type 4-5 invasion, where the matrix is also stroma is also myxoid looking, and the lymphoid response cannot go there. So the cells are individual cells of thin strand. They find the lymphatic very easily and go into lymph nodes very easily. You see, they have the connection. The lymphoid, the immune host response cannot invade or come to this myxoid stroma, where the pattern of invasion is type 3, type 4, and type 5. Now, because of the value of the pattern of invasion, and a lot of databases use this pattern of invasion as a core element in their databases. Therefore, we in ICCR use pattern of invasion heavily according to those three types I mentioned, and the Royal College of Pathologists of UK and also recommend the same, and also the other data sets like the College of American Pathologists, Royal College of Australia, etc. So they all use pattern of invasion as a predictive factor, histopathological parameter. What about degree of differentiation? Degree of differentiation, again, as I told you, now this came in early 1920s, right? But still up to date, we use this. It works most of the time. The well-differentiated cancers behave better than poorly differentiated or moderate. However, for all cancers, it is not the same. Sometimes a very well-differentiated cancer go into a lymph node much easier than sometimes in moderately or poorly. But overall, if you look at the majority of cancers, the way they behave, well behaves better in terms of prognosis compared to poorly differentiated. So the addition of all these histopathology parameters came quite late, but degree of differentiation has been there, as I said earlier, from 1920s. So we have shown this from our studies. Also, the level of differentiation correlates with poor prognosis and increased cervical metastasis. And also, it tallies with 5-year survival rate. What about lymphocytic host response? Now, when there is strong lymphocytic host response, we know that these tumor cells cannot find their lymphatics and blood vessels easily, but they have to overcome the lymphocytic host response. But a tumor which has hardly any lymphocytic host response, I told you, when you have these thin strands at the advance in front, the stroma is myxoid, and the lymphoid host response cannot invade this area. So therefore, these cases with lymphocytic host response much less, pattern of invasion more dispersed or non-cohesive, they have a much higher chance of going into lymph nodes. This tumor budding, that's also important. A tumor bud is the tumor islands less than 4 tumor cells. So this tumor budding is again recently shown that has a very significant prognostic value. Now, the tumors are classified into low grade and high grade according to the number of tumor buds. If it is less than 5 tumor buds at the advance in front, it is a low grade in terms of tumor budding. If it is more than 5, it is high grade in terms of tumor budding. High grade tumor budding is significantly associated with lymph node metastasis according to a lot of studies coming from India, Japan, etc. And even in early stage squamous cell carcinomas, there is a relationship between tumor budding and occult lymph node metastasis. So therefore, the presence of tumor budding can be used to predict occult metastasis, leading to elective neck dissection. Therefore, the tumor burden is a reliable and clinically relevant prognostic marker. Its simplicity, reproducibility, and cost effectiveness make it particularly advantageous for our part of the world, clinical applications. So I invite pathologists from Pakistan and this part of the world to embark more on research on these very significant histopathological parameters, yet we don't use them to good effect. Excision margins, I don't have to elaborate this much. A lot of people use this. Not a lot of people, all the surgeons, this is what they are keen. This is why they need our report to see whether they have done a good job, whether their margins are clear. Now, according to Royal College of Pathology guidelines, this is what I have been using and most people have been using over the years. And if it is more than 5 millimeters, we call it clear. If it is 1 to 5, we call it close. And if it is less than 1 millimeter, we tell the clinician it is positive. Lymphovascular invasion, again, the really important one in order to predict occult metastasis, etc. Now remember, our immune system does not allow, although there is a tumor embolus inside the lymphatic or blood vessel, to end up in a lymph node necessarily. It has to fight against the immune system in order to be successful and go into a distant site. But still, when we see this, we can convey this to the clinician. I think clinicians, together with other parameters, can decide whether they are going to do a neck dissection, especially in clinically N0 or clinically negative neck. What about perineural invasion? Yeah, this is a very important parameter that we see in salivary cancers in the oral cavity as well as in the various other cancers, including squamous cell carcinoma. Now, this is perineural because the tumor islets are around the nerve. Sometimes, rarely, we see intraneural as well. Now, the significance of this is, according to some papers, is more in tongue cancer. Some clinicians use this as a prognostic parameter, especially in tongue cancer. Now, for us to say perineural invasion is there, it's usually tumor cells in close proximity to a nerve surrounding at least 1/3. Remember, at least 1/3 of the circumference, or inside of any 3 layers of the nerve, right? As I said, that's the intraneural. But for the perineural, at least it should cover 1/3 of 1/3 of the nerve circumference. But it has been shown with many studies that the perineural invasion has a direct relationship with overall survival, disease-free and disease-specific survival, as well as metastasis. I'm sorry, my throat is not in good shape these days, so that is why you have a little bit of hoarseness. Sorry for that. What about bone invasion? Bone invasion is another parameter, as I said earlier, clinicians use more often than not whenever we say there is perineural, the bone invasion, they decide on the extent of the excision, how much bone should be taken out, etc. So the question that I ask here is it a common practice around the world to include important histopathological parameters in order to plan treatment? The answer is yes and no. Are there data sets including these things available? The answer is big yes. Now, this is the ICCR data set that I was talking about. Now, this we have revised recently. The group is chaired by our good friend Susan Muller from Atlanta, Georgia, USA. And we have a team. They're mostly from US, and we have from Japan, from myself from Sri Lanka, and Rosna Sen from Malaysia. Now, these are the elements in the ICCR dataset: the clinical information, operative procedure, specimen submitted. You see, all these things, if you include into this dataset after a few years, you have a very good dataset to analyze. The tumor site, operative procedure, tumor laterality, which side of the tumor that is, tumor dimensions, depth of invasion, pattern of invasion, tumor type. That is when it comes to squamous cell carcinoma. We know there are about 8-9 different types of squamous cell carcinoma, subtypes. So what type that is, that has a prognostic value ranging from verrucous to basaloid squamous cell carcinoma. The neural invasion, lymphovascular margin status, ancillary studies, whether immunohistochemistry and those things are there, it is, and molecular studies. So that's not a core in some data sets, and the pathological staging. But these ICCR core elements have been used by or adopted by the pathology bodies as well, such as Royal College of Pathologists, United Kingdom, and the College of American Pathologists, and the Royal College of Pathologists of Australasia. Finally, the prognostic, the prediction models. Now, a lot of people have been working on these things. Now, we have worked on developing prediction models over the years, and we have produced few models, but I expect the clinicians to use them and validate them. So that is where it is going to be important. These models have try to establish the relationship between histopathological parameters and overall survival, and these models have the ability to predict the possibility of metastasis. So these are the prediction models. You can see many of, actually some of them now, the Sirvadan et al., the De Silva et al., and Kalarakal et al., they are our models from my team. Now this is the latest one. We have the validated predictive model for risk of node metastasis in node-negative oral squamous cell carcinoma of buccal mucosa and tongue, the two common sites of oral cancer. We looked at various parameters. Now, according to univariate analysis, now some of these things are very significantly associated with metastasis and survival, like gender, the age, the tumor size, that is clinical tumor size, the site, pattern of invasion, and depth of invasion. Now, when we did the multivariate logistic analysis, they are strongly significant. You see, we used them to come up with the model: the sex, the gender, tumor size, tumor site, pattern of invasion, and depth of invasion. So we use those 5 parameters in order to build the model. Now you can see to a very reliable degree, it can predict the prognosis when you look at the depth of invasion and the pattern of invasion to 2 sites very efficiently. Now, if you look at, you see the with the tumor size, you look at the T1 tumor, this white means the chances of metastasis is very less. And then this red color means the very high risk, and all others are in between. Now you can see when you have a T4 tumor and the depth of invasion is high and they are discohesive, their chances of metastasis is very high. Although they are cohesive, when the depth of invasion is more than 10 millimeters and T size is either T3 or T4, they still have a very high risk of metastasis. Likewise, we have come up with this model to show the buccal mucosa and tongue in males and females, what is the effect of cohesive, discohesive pattern of invasion, the clinical tumor size, and the depth of invasion to decide what patients have the higher risk of metastatic potential. So that can be used to decide their treatment plan. In summary, ladies and gentlemen, histopathological parameters definitely play a significant role in predicting metastasis and survival. However, whether these parameters are taken into account in the maximum and appropriate way in treatment planning is questionable. So that's what I was trying to say earlier as well. Excision margin status is the most commonly used information from the biopsy report without argument. So clinicians should go beyond that. If not all, a few parameters such as depth of invasion and pattern of invasion and immune response should be considered in treatment planning. I showed you the evidence how important that is. And it is desirable to try and use proposed predictive models in prospective studies. That's very important. I am sure our clinicians, the clinical colleagues, the oral and maxillofacial surgeons, the ENT surgeons, etc., will use these models, and if not the models, at least these significant histopathological parameters in order to plan their treatment to give the patients better survival, disease-free survival, and overall survival. Now, my dear friends, now because oral cancer is the most common cancer in our part of the world, I invite you all to embark on research in oral cancer. Now, whenever we try to come up with these various documents internationally with the help of people from the rest of the world, now we do not have enough research coming from the part of the world where oral cancer is more common. Recently, the last year, we completed the Oral Cancer Prevention Handbook by IARC and WHO. Now, there also, we didn't have many studies coming from South Asia, except a couple of studies from India. We did not have significant studies from Pakistan, Bangladesh, Sri Lanka, where oral cancer ranked as #1 in males. So that is not good news. I think we should make teams, we should make the collaborations between oncologists, the surgeons, and pathologists to come up with better data, because, as I said earlier, oral cancer in our part of the world is not the same cancer. It's a different disease compared to the oral cancer in the rest of the world, where betel quid chewing is not a habit. So therefore, my dear friends, please embark on more and more research on oral cancer. At least in another couple of decades, at least, we should be able to see oral cancer is not the number one ranked cancer in our part of the world. Thank you very much for listening. Thank you.
Thank you very much, all the speakers and the audience. So now this is time for question and answer sessions. Is there any difficult question for the speakers?
Dr. Swales, I noted some confusion in some of the residents, that if the core shows classical features of fibroadenoma, still they tend to diagnose that as fibroepithelial. So would you like to elaborate it a little bit?
I think one thing I didn't emphasize, and I'm glad that you pointed this out, that the first thing, and done a lot of work on this, that our aim is to reduce the number of B3 lesion diagnosis, not to increase it. And that's why I tried to put many pitfalls there. People quite often make wrong diagnosis, like even sometimes I've seen people coming to me, even in UK, showing me the columnar cell change and calling it FEA, which is not. So I restrict the term of all these B3 diagnoses to as low as possible, and that should be our aim. If we have less experience, then we should consult our senior colleagues to reduce the number. And quite often, as you rightly mentioned, like in fibroadenomas, many centers in the UK, in a recent, in UK, there is regular audit of the diagnosis in breast screening program, and people can see where they stand compared to other centers and try to reduce it. Unfortunately, we don't have this data over here. So that's why I'm saying that this is very important to liaise with our other colleagues who are more experienced and try to reduce it. If you are seeing a lesion with a clear-cut boundary, with even if it is no capsule there, but there's a sharp demarcation and there's no stromal overgrowth, no increased cellularity, no mitotic activity, fragmentation a little bit can occur, but if it is too much fragmentation, then it's worried. But if it is too little fragmentation, then even because of the certain slit-like structures, they can produce that. Sometimes even larger fibroadenomas, excision opens up, you can see it, and gives you a false impression of the phylloides tumor, say, oh, this is epithelial leaf-like pattern, which is not. So you have to take that into consideration. But on the other side, I don't want you to miss the B3 lesions either. If you see, for example, if there is a fibroepithelial lesion, true fibroepithelial lesion, not hematomas. Hematomas can be fibroepithelial in some sense that you can see stroma there. With infiltration into the fat, yes, that's worrying. But if you have got clear-cut demarcation, no epithelial atypia, cellularity is mild to moderate, no stromal overgrowth, no significant mitotic activity, you should call it B2, not B3. Otherwise, the patient will go unnecessary open surgical excision. Yeah, that's your aim should be. As that I answered your question, I believe. Yeah.
Okay, thank you very much. Is there any other question?
Dr. Tilakratne is also online, so if anyone has a question. My question is Dr. Ali Khanum, you showed that picture with where the AI detected the dysplasia very nicely in the lower two-thirds of the epithelium. My question is, even on the slides, there's often interobserver variability with the severity of the dysplasia. How has AI tackled that issue of interobserver variability among pathologists?
So I think good question, but that was the whole point of doing it. You want to overcome that variability. I don't believe in the epithelial thickness involvement, and Prof. Tilak is there as well, and he can jump in. He's a dysplasia expert, much more so than myself. That is the extent of the features and the type of features that are present that are perhaps more important than the thickness of the epithelium that's involved. For example, when you see verrucous changes, you don't tend to see the typical full thickness dysplasia. In this case, it was the important thing was to identify at a cell level what changes were present and whether they were dysplastic or not, irrespective of whether the epithelial thickness was involved or not. And we've tried to step away from grading. I personally don't believe in grading. I believe in, can we call something high risk or low risk? And grading is meant to do that, but people who are seeing a lot of cases, of course, have got good threshold and experience to call that, but 90% of the people in the world who will be looking at those dysplasias perhaps don't have the same experience or background. And we need to simplify things. So that was, the 6-point and 2-point model that I described, that instead of thinking about the thickness and the grade, can we actually just look at individual features? And does that simplify things? If these 6 features are present, or 4 of these 6 features are present, this is a high risk lesion and is more likely to become malignant rather than thinking about and that variation. And using a smaller number of features tends to reduce the variation between pathologists as well. I don't know, Prof. Tilak, if you've got something to add to that. Nice to see you on camera. I was hoping to see you in Lahore. You missed out.
Yeah, I was planning to come, but I promise you also that I will try my best to come, but various commitments prevented that. Yeah, yes, I'm sure that Ali's work on dysplasia is exceptional. And our thinking, with time, now we think what is more important is whether there is dysplasia or not, rather than grade, right? So, because we know whether it's mild, moderate, or severe, only some of them transform into cancer, right? So therefore, it is important for us to recognize whether there is dysplasia or not. So AI can do it very, very well. And also, as Ali said, now the thickness of dysplastic area, there is again a lot of debate on that, but according to the WHO classification this time as well as the previous one, we have left provision for the pathologist to upgrade grade of dysplasia if there is severe degree of the cytological atypia in the lower part of the epithelium. So those things are there. Again, whenever somebody speaks about dysplasia and talking about 28 features in the classification, I feel a little uncomfortable because I was part of it. And yeah, with your very nice seminal work, Ali, I think next WHO classification, which we will be starting probably toward the end of the next year. So we should definitely reduce the number of features to bare minimum. Otherwise, where the subjectivity, intra-examiner and inter-examiner variability will never be reduced.
Okay, so any other question? So can I ask a question? Okay, this is question with the Dr. Tilagaratne and Dr. Ali can also answer. So what's the criteria for in the oral squamous cell carcinoma tumor stromal ratio, and how can we measure, and how many number of blocks or the number of sections are required for tumor stromal ratio in a exine specimen?
Ali, go ahead.
I was going to let you start because and then I can jump in.
Yeah. No, it's true, as I said during the lecture, the tumor stroma ratio is, with time we have realized it's a very significant histopathological parameter. Now, significant number of pathologists now divide the cancers into stroma rich and stroma poor. We know the stroma rich cancers, the immune response is less. So that may be one of the features why it has a poor prognosis. But I'm very sure it is one of the easiest areas for the AI to recognize the stroma poor and stroma rich cancers. I'm sure that Ali has more experience on that.
Just building on what you've said, so the stroma-rich areas and the evidence that's there shows that those are myofibroblasts or cancer-associated fibroblasts. So you've had the epithelium mesenchymal transition perhaps, and those fibroblasts have changed their phenotype, and they tend to, of course, express a lot of SMA. And there's been quite a lot of papers which have shown that in the stroma adjacent to the tumor, if you are getting increased smooth muscle actin expression in squamous cell carcinoma, it's a more significant predictor of outcome than anything else, based on the tumor itself. And we've also looked at bone invasion and a lot of other features and the advancing front and margins, and it looks like that stroma and the quality of the stroma or the change of phenotype of the fibroblast seems like it's very important. And I think it's a matter of time where we will actually bring in something like SMA, for example. Right now, like Prof said, we just tend to say stroma rich or stroma poor or desmoplastic stroma, and we know desmoplasia is a sign of poor prognosis. But something as simple as SMA will just come in practice in terms of how rich or how much expression there is, and that tells us that that's going to be a poor prognostic factor. In terms of using AI to detect that, it's not that difficult. But I think the first thing would be to implement those AI models for the more established tumor-based features. But our understanding of the stroma is still developing. But it looks like the phenotype of these stroma-rich tumors is different. They also are more senescent. They also secrete different types of proteins which are more pro-tumor, and also stop the immune cells from attacking. So there are multiple actions that they've got. And the other interesting area is, hopefully long-term, is that those stromal fibroblasts are easier to target therapeutically. And perhaps you don't get as much side effects from some of the earlier evidence that's emerging. So they've got potentially some therapeutic implication as well. I'm not sure whether that answers your question.
Yep. Thank you. Thank you very much.
And also we got to remember the oral cancers in our part of the world, as I said at the lecture, the majority of them occur in the background of submucous fibrosis. The extracellular matrix that we are talking about in our part of the world is not the same. So therefore, the significance of this trauma, rich and poor, we have to interpret very carefully. And that is why the extended the request for you all to embark on more oral cancer research using samples from our part of the world.
Okay, any other question?
Yes, so this might be a silly question, but
There's no such thing as silly questions.
I do read about this differentiated intraepithelial neoplasia in vulva and vagina. I don't do much of the head and neck. Is there any concept of differentiated intraepithelial neoplasia in oral mucosa, and how you deal with regards to digital pathology?
A very interesting question. Actually, this concept of differentiated dysplasia is emerging quite rapidly, and we do recognize and realize that there is a subtype of dysplasia which shows slightly different features, which we are now beginning to call differentiated dysplasia. It's not exactly the same as other parts of the body as you described. It may not show the exact sort of typical features of dysplasia, but we now know. And there's also belief that perhaps we need to move towards more pattern-based classification of oral dysplasia. And differentiated dysplasia is definitely one of those which becomes or can become difficult to grade as well. Verrucous is another one because they don't tend to have those classical features. So they don't tend to follow the same guidelines, like, for example, WHO or the standard dysplasia that you see. So you have to have a more pragmatic approach. But differentiated dysplasia is something that's becoming more and more recognized in the oral cavity as well. And most of them tend to be sort of, I would say, well behaved in the sense that the rate of progression or transformation is slower than the more basaloid looking dysplasia. But because none of the literature that exists so far has actually looked at them in terms of separating them, we don't exactly know yet. I don't know whether you've got anything to add, Prof.
Yeah, the concept of differentiated dysplasia, actually, when it comes to oral cavity, we have the strongest team in Scandinavia. Actually, the time when we came up with the WHO classification also, they wanted to include differentiated dysplasia. But the reality is, some of the features that we have included in architectural features includes differentiated dysplasia features. But yes, you are correct. But in the oral cavity, we don't emphasize on that. But I remember about almost 20 years back, Japanese oral pathologists they came up with a document. That document mentioned about differentiated dysplasia in a different context. Uh, yeah, although it is used heavily in the vaginal epithelium, but we don't use it in the oral epithelium. But there are groups working on that. So we never know whether it will, come as a main thing in the future. But we need a lot of work in the oral epithelium.
I tend to add it to my reports. I mean, you're giving the conventional grade of dysplasia, and I'll just say this most likely represents a differentiated form of dysplasia. In case 10 years down the line, someone wants to get out the cases and do something with them, perhaps there's a little bit there to help and build that database up.
Correct.
Thank you very much for enlightening us. Very wonderful presentations from all the presenters. My question again might be a bit silly in a way that when we study dysplasias, not that we study different grades of dysplasias, like conventionally we are studying from ages at mild, moderate, and severe. Where we have no frank malignancy occurred yet, we always see there is either orthokeratinization or parakeratinization. Do we have any evidence or are there any studies that can tell what is the significance of these two things? Can we comment on the prognosis, or is there any prognostic efficacy, or is there any can we comment on that parakeratosis or orthokeratosis can comment or can tell us any relation between the progression of the disease or any prognostic indicator? So I wanted to know the significance of these two things, parakeratosis and orthokeratosis, related to the progression or the prognosis of the disease. Are there any studies done yet?
Do you want to start, Prof, or should I?
Yeah, you can, Ali. I will add after your comment.
Thank you.
So, yeah, very, very good and interesting question. The challenge with the oral cavity is that normal is different for pretty much every subside. So the cheeks are different to the tongue, and the side of the tongue is different to the top of the tongue, which is different to the underside of the tongue. So the important thing is what's normal for each side. So I think the presence of orthokeratin on things like gums and palate is fine, but when I see orthokeratin in the floor of mouth or somewhere else, that it worries me, because particularly when you see it in the form of clonal change, that abrupt change between parakeratin and orthokeratin. So it's just within an instant it becomes, you can see it's changing from para to orthokeratosis. I tend to consider it as part of the spectrum of differentiated dysplasia, and offer advice based on that as well. The 2-point and 6-point model work that I mentioned, we looked at that abrupt keratosis as one of the features. But because we had just 5-year follow-up, in that it didn't show a significant correlation. But I think it's because it takes longer for these lesions to progress. And I still think it's a significant risk factor, but perhaps needs a little bit longer, although it may have a higher risk longer term. Like you said, there's perhaps not a lot of evidence out there, and I think in the new WHO features that has been added. So it's definitely something that we are thinking about, and we just need to build more evidence.
Yeah, I think well said. I think you said everything. So we have included abrupt keratinization into the new long list of features, but keratinization and dysplasia and progression, we don't have enough studies, but we know some lesions without dysplasia also. At the moment also, we are not sure whether they have a significance or not. That is why, if you have read, there is one condition some people would like to call keratosis with unknown significance, so without dysplasia, especially our American colleagues use that term. So it's the keratinization and its significance to the progression is one area where actually people need to do more research, because we don't have even a single solid paper to say paraketonicization, orthoketonicization, and what is more significant in terms of Malgin transformation. Yeah, that's a good question.
HPV positivity on AI. That was quite interesting because it's sort of like AI is predicting the prognostic markers as well. I just want to add that we had a study here with a team of FAST here, and we used the breast scores on them, and we just provided them the data that this tumor was this hormone receptor is HER2 positive. And at that time, that algorithm detected with 95% accuracy that this tumor will be HER2 positive or negative, and then so it's quite interesting because eventually I think it would be, as you said, it would be we will be having results more quickly in this way, and probably a bit cost effective as well, because you'll be investing at one time and then you'll be getting it.
I think it's definitely the future. I mean, in the UK and the West now, there is a lot of AI models that have been certified for clinical use, particularly for MSI detection and colorectal cancer and ER, PR prediction on H&E based features as well. We are seeing more and more. I think where they are important is perhaps ruling out the negatives, most importantly. And even if you can rule them out because significant proportions are negative, then you can perhaps focus on the ones that are going to be positive and do some further testing on those. But the models are getting more and more sophisticated. Again, it depends on the amount of data and the quality of data that goes in there, and that can help. But I feel like particularly in low resource settings where you may not have all those facilities, and also turnaround time-wise as well. We did some work on a breast cancer model that could predict ER, PR, and HER2 status on H&E alone, which again showed quite decent 90% or so, but it was almost 100% for negative cases. So the conclusion was we can definitely start thinking about using them for the cases that are negative. For the ones where they are positive and potentially the scoring of the positive, we're not quite there yet.
So no more questions. So AI is doing a great thing. So,
but the problem with AI is also there's a lot of noise in the AI sphere. So don't believe everything that you see about AI. Is
yeah,
not
I
going
was just
to
about to ask you, should
change
I
the world.
start to look
And
for another job?
if I had a penny, if I had a penny for every time someone asked me, is AI going to get pathologists out of their jobs? I always say the same thing. AI is not going to replace the pathologists, but pathologists who use AI are going to replace the ones who don't, longer term. It's going to be a help for us, just like immunohistochemistry, just like molecular testing. It's never going to replace it because AI can't make those judgment decisions or clinical decisions yet, and it still needs our input and oversight. Just how we use them. For example, I give the example of Google Map, right? When we go Google Maps, we're going to use it to make our life easier, right? Or you can just try and get lost and keep asking people on the street where you want to go. So it's just like that. It's going to be another tool that's going to help us get better, perhaps improve our efficiency, allow us to get more sort of quantitative type outputs. I don't know whether Dr. Sohail in the breast sphere, how much noise there is about AI and what people are thinking. But I don't think it's going to put anyone out of jobs. But I think it's very important for us to upskill ourselves with digital pathology and some of these computational things, because that is definitely the future. I don't know.
Our administrators were very happy when they planned to buy a digital scanner, because they believe that the digital scanner will give the diagnosis and they will reduce the number of pathologists.
Okay.
So we had to inform them that
it's actually more work. You need to hire more people to scan and quality assure and all that. And longer term, I think with digital, the advantage is the audit trail and the quality and whether you can do a lot of stuff with it. And in the short term, the advantages might not be immediately relevant.
Currently, there are at least 2 or 3 advantages, I would say, in the field of breast pathology. One, There are 2 or 3 advantages in the field of breast pathology. Number one, that we can report more quickly excision cases, because in the past we used to mark the slides all around and then measure the size of the lesion in multiple areas and then looking at the distance. Now we look at it globally, the whole slide on a screen, and then you can measure it. You know exactly which are, I mean, even if you draw 2 or 3 lines, it won't take. So it significantly reduced. I must say that in the past, suppose if I was using half an hour to report an excision, now I can do it in 10 minutes. So it reduced that much time. That's number one. Second thing, it improves our review in the MDT, because when I have looked at, or my colleagues have looked at the excision cases, we have already marked that area and selected the area where we made the grade and the type and vascular invasion and the distance from the margin. So anybody's reviewing it, they look at only those snapshot selected area, and then they can, otherwise you had to look at all the slides and the markers and all that. So improves that on the MDT side. Third thing, I find it very useful for, particularly I must say, for this conference and symposium. I prepared everything online because I did not have much time when I was in my department. All the time was diagnostic work. I asked them to scan all the slides which I needed, although by looking at the diagnosis and reports, I selected the cases which I want to present this. They scanned it, and when I was on transit in Dubai, I sat there and accessed all those slides on my computer and took the snapshots and prepared the presentation. Although I was slightly worried that by taking the images on the camera, which is much better and better resolution, but I'm sure nobody has recognized that this was not as fine resolution as you.
A little worried about.
Yeah,
But
there was some. Yeah,
scanners are getting better with every day as well.
Yeah, I could have, I'm like experience on that. I would say in some of the images may not be that much resolution, because I should have selected the larger inner and then they shrink it out, so that becomes much more, clear on that. So these are the 3 things. Now coming to the ERPR and HER2, and even the image diagnosis, we, purchased this IBEX model. And I was very impressed, particularly with the prostate one. I thought it will help in, but looking at biopsies and doing ERPR compared to doing it digitally, if they do it automatically and give me, but at the moment they have not validated so far where we can just look into that. We have to check it again, and this takes a lot more time. So when I was just coming out here to Pakistan, I saw an email from the department that they have stopped using this IBEX screening anymore, because this is not cost effective. Because if I put the slides, it takes hardly 30 seconds for me to give the ER and PR score. Yeah. So it don't take much time. So I think we are not on that ER PR HER2 side, but certainly yes, for reporting excision, not for the biopsy. Yeah. Even if reporting excision is very good, and doing MDT is very good, and working from home, and it improves your quality of life too.
Yeah.
Because you don't have to be in the department all the time. You can do remote working from anywhere, and you can get second opinion quite easily and very quickly.
And it's quite ergonomic as well in terms of your posture as well, so you can work flexibly. But for prostate cancer, those models actually perform really, really well. For the dysplasia as well as carcinomas, and the IBEX ones that Dr. Suhail has mentioned is now used pretty much all across the world.
So I thank you all the speakers on behalf of Shaukat Khanum Hospital, and inshallah hope to see you again next time. So that's it. Thank you so much.
Thank you very much.